and that she's still around. In a way, I'm even thankful for Bob, who, because accidents enabled her to stay a bit longer. That's a bit cynical, but it comes from heart. And that is, the future is also MCH at Harvard. It should be, it was, it will be a home, an intellectual and a social home. This was Tuesdays. Honestly, this is a picture from Tuesday night when 27 MCH concentrators, as we call them, funny word, concentrators, graduate students mostly, came, and we went out to a nice restaurant and had tapas. So that's the last Tuesday's event. It is a social home too, and that's Bethany who organized it with me. Thank you very much.
Hello, everyone. I had the tapas, they were great. So my name is Isabel Janmay. I'm an MPH student in the Department of Social and Behavioral Sciences and a medical student at Case Western Reserve University in Cleveland, Ohio. So it's my pleasure to introduce Dr. Jonathan Litt. Dr. Litt is a neonatologist and perinatal epidemiologist. He obtained his medical degree at Case Western Reserve University and then completed his general pediatrics residency training at the University of California in San Francisco. Dr. Litt then came to Boston Children's Hospital in 2008 for fellowship training in neonatal perinatal medicine and the Harvard Pediatric Health Services Research Fellowship, through which he obtained his Master's of Public Health degree. He went on to earn a doctorate in social and behavioral sciences here at the Harvard T.H. Chan School of Public Health. So please join me in welcoming Dr. Litt, who will moderate our panel discussion.
Thank you so much for that lovely introduction. If I might at this time invite our speakers actually to come up to the front. And as we're doing that, and to have a seat, thank you. And this is the interactive portion of this part of the afternoon. And I'd like to invite anyone with a question to please come forward. There's a microphone here in the center of the room. And as you're gathering your thoughts and thinking of questions, I'll take the moderator's prerogative to start with a question. And this really stems from actually, Dr. Liu, your talk, but any of you can answer. I'd be really interested to hear your thoughts. You talked about one of the major challenges in MCH work has to do with the silos that exist between institutions, disciplines, and so forth. Being a good social science student from Harvard, I always think about what are the causes of the causes, what are the drivers, what agency, right, and accountability. What's responsible for those silos? Because I think to move past them, it's nice to talk about it, but we really need to identify what's causing them, what are the barriers, so that we can move forward.
Start with the easy one.
Don't be shy.
Yeah, it's remarkable. We see this across many disciplines, and
Yeah.
they begin with their own approaches, their own origins, their own methodologies. And one of the advantages of looking at things historically is you do see these boundaries do crisscross over time.
Yeah.
And there are these key moments when somehow they say, it's time to be interdisciplinary. And that could be 1920, 1950, or 2018. So it does happen as people start applying, either both go further upstream and realize that they're talking about the same problem in a different way, or they realize that they can share one another's methodology across these associated problems. So it really they're having these serial invocations of imagination to these problems. So I'm not sure the answer to why, but we'll show you as far as the how or that it does happen. They do cross over time.
So I think if we talk about kind of promoting transdisciplinarity, certainly in the academic setting we have to walk the walk and not just talk the talk, right? Because I think if transdisciplinarity is really kind of valued in an academic setting, then we have to rethink how we support and promote transdisciplinary research. And kind of given how assistant professors gets promoted and kind of whether you get listed as a PI versus a co-investigator, what counts, whether you get listed as a first author or middle authors. Those things may make sense once upon a time, but in terms of if we really want to speak to the value of transdisciplinarity, then we have to kind of engineer the way we the way we promote faculty advancement based on that.
I might add from my limited perspective that the solids obviously don't only exist in public health, but they exist between separate communities. There's a public health community, there's a clinical community, there's academia, and there's the community. And I think Marie's career has really modeled, I think, the approach that brings these various communities together in a way that can effectively find solutions for some of these problems that have been identified.
Great. Thank you. I think we have one question, please.
Hi, my name is Christina Gable, and I want to say on behalf of the March of Dimes, a deep and heartfelt thanks for Dr. McCormick's life and work towards MCH, as well as many of the folks who spoke this morning. My question is directed at Dr. Michael Liu. I really took to heart your intriguing questions about technology. And I know that when we have these widespread uptakes of technology, it often, as you said in your presentation, can leave large portions of the population behind. While smartphone usage isn't ubiquitous, it's certainly a quite big reach, even among vulnerable populations. So I guess I'm wondering, what sort of cross-sectoral partnerships do you think public health, and especially public health students, need to start exploring across the industries in order to make sure that equity is the focus of technology uptake?
Right, so I think this is where public health can really play a leadership role, because the folks are developing the technology, and whether it's the industry, the entrepreneurs, whether it's the clinicians that could be, or the women and families who are the end users, they're all kind of driven from kind of certain perspective, but public health should have that broader systems perspective in terms of how do we actually design the system in a way that works for everybody? How do we create the conditions where technology is put to use to advance health equity and not to widen disparities? So I do think that public health as a team sport can actually play a very important role in terms of kind of making sure that we take a systems perspective to incorporate technology and into the design of our healthcare.
Don't be shy, please. If you've got a question, please come forward. But I will take the opportunity to ask another question because I am curious. Dr. Tiemeyer, thinking about the future, the present and future of MCH, and since you have just come from Europe, thinking about a cross-cultural, perhaps, comparison, particularly thinking about some topic like maternal mortality and infant mortality. I know there are a lot of state-to-state comparisons, a lot of groups working on quality improvement in states, comparing themselves to other states within the US to try to make improvements. Are there any efforts here to think about as a country, looking and thinking and cooperating, learning from those countries who are doing it really well, to see what we can do to implement, those good things and get rid of the things that aren't working?
I like the question a lot. I'm not sure I'm the expert in it because I do come from Europe, but I'm not sure this is a sort of,
sure.
But here we go. My go at the question would be that that's part of the thing I wanted to say, is that measures like infant mortality and maternal mortality are important indicators, but they've also become sort of like an Olympic bar that you can make or not, and that means there is doping, so these numbers are sometimes even, there was a time when we cheated. I know the Netherlands, I was once involved, they cheated with infant mortality because they took, I don't know how they managed 2 weeks off the off the record, they counted it differently, but then other countries treated it in a much more blunt way. So I would warn against, at the same time, of course, don't get me wrong, they are very, very, very important bellwether indicators of an underlying problem. Now, what I've seen is, so there is perhaps a healthy competition in the US states. Texas doesn't want to be behind. That's actually, in a way, I endorse that. I think, get your act together and act. There is little across the world in the way, because everybody says we've got different underlying root causes, we have different underlying healthcare systems. I don't see, other than on a very, very, I wouldn't call it superficial, but very focused way of dealing with, let's say, renal failure, I don't see too much cross-country. Nobody is ready to change the healthcare system radically just because, you know how difficult it is. The policy in the last years has shown how difficult it is to change it fundamentally. There was one big effort. Yeah. So it's little.
Thank you. Dr. Perrin.
So Michael, you mentioned something about happening in November. I don't remember what it was you were talking about. But, and you talked about the state houses and Congress and so forth. So what are the ways that MCH science can and should influence the thinking in November, or the preparations for November? This is not just for you, it's for all of you. And how might MCH science inform new people in those roles?
Well, I'll start. I certainly think everything that we've been learning in the last couple decades about the life course health science, that if we really want to do something about maternal mortality and infant mortality, you start by improving women's health. Right, and I think, and that's why it's imperative for us to be protecting the gains to women's health from the ACA and defend against the assault on women's health by the current administration and Congress. And so things like the proposed defunding of Title X and Planned Parenthood, things like the contraceptive, the religious and moral exemption for contraceptive, the weakening of protections around pre-existing conditions, around essential benefits in the ACA, the restricting eligibility, benefits, and enrollment through all the Medicaid waivers that are going around the country. All of those things are happening that could really take women's health back by decades. So come November, we need to hold folks accountable.
Are there any other? If no one else has a comment they'd like to make, Dr. Gimlin.
Well, I think my question is for Dr. Persley, but maybe others would have a thought. What's standing in our way of understanding why babies are born too early?
This is where I get to say I'm a pediatrician, not a doctor. I think there's a real need to invest in the work that's necessary to answer those questions. I think it is it's a very complicated problem. I think people are really starting to really appreciate how complicated it is. When I started, when I was a resident, it was, well, it's all about prenatal care. It's all about prenatal care utilization. And clearly that is, there's a lot more to it. I mean, Michael presented a model where prenatal care could be transformed in a way in which there aren't actual prenatal care visits or a continuous dosing of prenatal care support that might be more effective. But I don't think at a very fundamental level, we don't understand how social forces get translated into biologic outcomes. And I think in the end, that's the answer to many of the disparities which represent what would seem to be opportunities to improve preterm delivery. It takes more than physicians to answer that question. It takes more than policymakers. It takes sociologists. It takes people on the front lines in communities to help both identify the causes of these, but more importantly, find the effective interventions. I really feel like I'm at the adult table here.
You belong.
Sitting
You
with
belong.
these luminaries, but that's a short response to a very complicated question.
If
And I'll just add to that. I think that, a lot of it has to do with how we've been doing research for many, many decades, right? We take these snapshots during pregnancy and then we try to understand birth outcomes. We keep our tunnel vision, it's pediatricians, it's obstetricians, it's sociologists, and so forth, and we're not talking with each other. And so I think the way to really accelerate that breakthrough in our understanding of preterm birth, it's in the design, it's in the system, it's how we can just fundamentally transform how we do research in MCH that will get us to a more comprehensive understanding than what we're able to get from snapshots and tunnel vision.
And to contextualize a little bit, we don't have a very sophisticated view about what happens at term delivery, right? Like the biology, at least when I was in medical school, forgive me if it's changed, and there is a very, a clear understanding about the biology of what causes labor. So I think that gets to the point, right? It's thought of, okay, well, this is, our focus in health and in science is disease focused, not understanding typical development in human biology necessarily in populations. And so this is thought of as a naturally occurring event. So of course we don't really think about it very, very carefully. One thing that I have learned from Marie in my years working with her is always to step back and think, are we asking the right questions? And are we using the right tool to measure, to get to the answer? So I wonder if I could ask each of you, what questions should we be asking, right? And are we using the appropriate tools at the moment? We were just talking a little bit about metrics around infant mortality. Maternal mortality is about being sort of a blunt instrument and useful to a certain extent. Well, what should we be asking?
Well, Jonathan, you could respond to that question better than I.
Sure.
And I alluded to it in my presentation, but we spend, there's a tremendous focus on neurodevelopmental outcomes, restrictive, definitions, very expensive studies to do, and frankly, that's not what families are looking for. Predicting a range of IQ outcomes for families is not helpful to them. They want to know what their children can do, and you and Marie have really, I think, voiced the need to function more on functional outcomes. And I think that's a particularly important place to focus, particularly in view of the need for translation. What do you do about it? Because I don't think we have a clue. And we talked about the sort of the social effects on preterm delivery and infant mortality and morbidity, but even when these babies survive, and Marie has written extensively on this, these social barriers don't stop having effects. The long-term outcomes of these babies is largely contributed to by the families that they're born to and the social circumstances of those families. So at least there are a couple of areas, I think, where we should turn our attention.
We'll all have a go otherwise.
Yeah.
So you started. What questions? I liked today's talks. Michael, that was a perfect keynote speech because you had the big picture, and then we tried to work into some details. So what's the questions? Of course, how? The big questions he put on the table. I also have, I think it's important that MCH perhaps gets involved in policy, holds politicians accountable. At the same time, we must also realize that working in MSCH, educating students, it will not be so easy to change income inequality. That's, for me, sometimes that's a frustrating thing to have as a goal. So I think what I would like to, and you've seen it a bit, coming from a child developmental perspective, what is sort of interesting there is that we have fought in that field for many years against the medicalization of psychiatric child developmental care, which is really a disaster, and essentially at the end of the day there's not essentially one or two perhaps at most Ritalin, and that not really much effective medication. But what really helps was not always, were two things that the field could agree upon. One is education, and the other is a big, sometimes don't know how to know, it's the family structure, family well-being, family, the composition. And I think there is a lot of, so part of what I want to do is focus on these themes where I think MCH focus can do something. So what can we do? Education is broad. It can be from family planning education or pregnancy spacing or broader education, or what I showed was the homeless children, where it's preschool education, which I think is extremely effective. Extremely effective. You could show that. That could be whackingly effective. And the other is a harder one. Don't note that. I put that there because I loved it in the paper of something Neil Helfom. This family absence, father absence, and that's just one word because it says. You see it in the homeless families too. That's mostly single mothers. So that the US actually has not one of the best records on that domain. And to me, it ties in with things. So I think there, and I don't know how to bring the father back to the table. If I had a slide which I took out of my talk that was sort of a family dinner, and I don't think that works at all. And we can't do anything. So that would be a challenge. But at the same time, I noticed that even the homeless children, when you read it up carefully, father is sometimes squeezed out of the picture because of bureaucratic regulations. Mm-hmm. So I'll stop here. That was a long talk. I'm sorry. You want to have your coffee.
Thank you.
But I do think of family focus. I'll pass it on because you do have to have what are the big questions?
Yes.
So daunting.
Or measure, or what's the one? Yeah.
So I'll go quickly in conversation, but coming from a historical perspective and from the Department of Global Health and Social Medicine, where on the one hand we've seen that from the 19 teens onward, they've intuited this relationship between what happens during development and the lifespan of the individual. Some intuitive notion of social determinants of health has been there for a long time. It's still, here we are, a century later, and despite the fact that certainly rates of morbidity and mortality have improved, but the inequities still persist this time, and would certainly call for ongoing attention to these upstream determinants of health and the way that structures of inequality have led to these downstream outcomes. At the same time that you work at these interventions, but not to certainly keep people's feet to the fire in these more upstream determinants. And again, historically, some of these things we talked about were at the Teddy Roosevelt administration, FDR's administration, Johnson, Kennedy. So when we talk about November elections, you see this impact of what happens in November every 2 to 4 years. So keep, certainly from a political standpoint, keeping feet to the fire around those more extreme issues.
I'll just add, I guess, four quick questions. First is, are we looking early in, right? So is there such thing as fetal origins or paraconception origin of preeclampsia or preterm birth? Okay. Second is, are we looking deep enough? So are we looking really kind of deep into the root causes of these poor birth outcomes? And how do these social determinants, how do they get under the skin? How do they get inside the womb to cause these disparities? The third thing is, who else is looking at this? And I think we don't do that enough. I was very disappointed that I was really looking forward to 25 years of National Children's Study to answer a lot of these questions. So for good reasons, when that study got stopped, I realized that there are a lot of other countries that have their own birth cohort studies that are following, so is there some way that we could actually create a global collaboratory of kind of MCH that's really trying to like help solve some of these problems, answer some of these unresolved questions. And then lastly, as I had mentioned before, probably most importantly is what can we do about it? And I think we haven't asked those 4 questions hard enough.
Great. Thank you so much. I'd like to thank you all for participating in our Q&A. If I can ask for a round of applause for our speakers. Thank you. And now I believe we'll have a brief break before the second half of our program.